Okay, good morning to everybody. As a chair of the steering committee of the NPA's Council of National Psychiatric Association, it's my pleasure to welcome all of you to the third webinar about effective psychotherapies for depression, the state of art, and the EPA application for mental health services. As you already know, we have with us as a speaker Professor Pim Cuijpers, who is a leading world-renowned expert on research on psychotherapy. I take this opportunity to thank again Professor Cuijpers for his great availability, and I thank also to Dr. Thomas Gargot and Dr. Selin Tanyeri, both members of the Psychotherapy Section of EPA, who will be our discussant today. And now it's my pleasure to leave the floor to Professor Koray Bazar, Secretary of our steering committee, who will be the chairman today. Please, Koray.
Thank you, Bernardo, and thank you all for being here with us in this nice, good afternoon. I will try to introduce Pim Cuijpers briefly. He is a Professor Emeritus of Clinical Psychology at the Vrije Universiteit Amsterdam, and he is the director of WHO Collaborating Center for Research and Dissemination of Psychological Interventions in Amsterdam, the Netherlands. He is specialized in conducting randomized controlled trials and meta-analysis on prevention and psychological treatments of common mental disorders, and today we'll be talking about depression. His work is aimed at prevention of mental disorders and psychological treatments of depression and anxiety disorders and internet-delivered treatments as well. He has published more than 1,000 peer-reviewed professional publications, and he is the editor-in-chief of the Journal of Consulting and Clinical Psychology. In Web of Science, he is currently ranked #1 in the field of psychiatry and psychology as top author, and he is in the list of highly cited researchers. And according to Expertscape, he is the world's #1 expert on research on psychotherapy. And we would like to congratulate him again because he recently received the American Psychological Association Award for Distinguished Professional Contributions to Applied Research, which is an award that is given to a psychologist whose research has led to important discoveries or developments in the field of applied psychology. So the floor is yours, Pim. Thank you for being with us.
Thank you very much for the kind introduction and for the introduction to talk today, because I think psychotherapy is an important treatment, and certainly for depression, there's a lot of knowledge that we know about what works and for whom it works. And what I'll try to do today is to try to summarize all that knowledge. And I will first share my screen. I hope it works. Usually it works. Here we go. And I'll start my slides. So can you see my slides? I hope so. Okay, yes. So what I want to do today is I will talk about meta-analysis. And I think we are now going into a next level type of meta-analysis, and we call that meta-analytic research domains. That's not just a meta-analysis or a series of meta-analysis. It covers a whole area, meaning that in these domains, we collect all the knowledge about that domain that can be known from randomized trials, because we collect all the randomized trials in that domain, and that gives much more opportunities to examine, in this case, psychotherapy for depression. So that's the first part of what I want to explain. Then I will summarize what we know from psychotherapies for depression, based on that, on these next level meta-analysis. And with these meta-analysis, we can answer a lot of research questions, and that's what I will give the overview of. But because we have all these trials and all these meta-analysis, we can also take a step back and look at the whole field and try to get some recommendations for research and practice, which are not specific for one trial or meta-analysis, but that's the result of looking at the whole field. So that's what I want to do this afternoon. And so I first try to explain briefly this idea of meta-analytic research domains. And if you want to know more about that, you should read this paper where we have tried to explain the idea. And what it basically means is that when you do normal meta-analysis, you have one research question and you you do the searches, you have a PICO to collect all the trials examining that question. For example, one specific type of drug versus placebo, let's say paroxetine for depression versus placebo. So you collect all the trials comparing paroxetine with placebo. You extract all the data from these trials. You estimate effect sizes from these studies. You make one pooled estimate of the effect sizes, and then you're done. That's what you do. And then the next year, when you want to do another meta-analysis, you take another drug or you want to compare paroxetine to another antidepressant, and you do that all over again. You do the searches, you collect the trials, you extract the data. What we do in these meta-analytic research domains is different. We do not look at one intervention or one target group or one comparator. We collect all the randomized trials on psychotherapy for depression, regardless of the target group, whether it's youth, adults, older adults, the perinatal depression, whether it's compared with another psychotherapy, pharmacotherapy, combined treatments, whether they compare individual therapy to group therapy or individual versus digital interventions, doesn't matter. We collect any randomized trial on psychotherapy for depression. And it's a living systematic review, meaning that we can, that we update the searches every 4 months. So every January the 1st, May the 1st, and September the 1st, we update the searches and collect all the new studies that have been done, meaning that we have a complete overview of all the randomized trials on psychotherapy for depression, regardless anything. That approach gives us the opportunity to describe what do we know about psychotherapy for depression. So everything that is examined in randomized trials is in our database. And that has a lot of, so we have, I will show you later on what you can do when you have all these trials in that living systematic meta-analytic research domain. But what I want to do first is open science is a very important part of our initiative. And I will show you, I will just to show you how it works. And now I'll go to my browser and I will try to make this a little bigger so that you can see, that you can all see it. So if you go to the website of the project, it's called www.metasci.org. You can, if you're online, you can do this just while you listen to me. And if you you see here a button, Start Exploring. And if you click on mental health professionals, you see here a lot of databases that we have made available. So it's the first one is psychotherapy versus control groups for depression, which is by far the largest database we have. But we have also databases on panic disorder, on suicide, on problem gambling, on generalized anxiety disorders. And we're continuously expanding all the data sets that we have available. And you can go there. So I will, because we're talking about depression today, I will show you how it works if you go to psychotherapy versus control groups. Then you get into a new screen where you can start analyzing. When you click the button, Start Analyzing, you get into a new screen, and there you see all the trials that are in our database. So it's 400 something. And what you can do on the right side of the screen, you can select a subset of studies. So for example, we're interested in older adults, and we want to see if problem-solving therapy is effective in older adults, just as an example. So we select problem-solving therapy for older adults. Now we click on Update Table, and here you see the studies on problem-solving therapy for older adults. And here you see a button, Run Meta-analysis. And when you run it, you get into a new screen, and you get a full meta-analysis. So here you see the effect size with a 95% confidence interval. You find the prediction interval, the numbers needed to be treated. You see the between study heterogeneity. You have another tab with all kinds of plots. Here you can click on the forest plot, and here you get a forest plot. You can examine what happens when you exclude outliers, because that's often a problem. You have all kinds of analysis of publication bias. You get an overview of risk of bias, and you can even do moderator analysis. So you can go to this website if you are interested in group therapy for perinatal depression. If you want to know, is psychodynamic therapy also effective in East Asia? You just go to the website, select the studies, and run your own meta-analysis online without any additional software. And as I said, we have all kinds of data for depression, for all kinds of other mental disorders. We're now making all these meta-analysis across different types of mental disorders. But we have also, if you click again, go to the Begin screen again, and click on Start Exploring, you also see that there's one possibility for patient and other stakeholders. So if you go there, you again get into a screen, and you get an overview of the disorders here that are currently in there. And we're now talking about depression, so we proceed with it. And then you can select a specific type of treatment. So for example, let's say we're interested in behavioral activation, and we click again on Proceed for adults. Then you get into a new screen where we try to explain in very simple terms what the outcomes are. And here you can see that if you get behavioral activation, that 53% of patients who received the treatment improved by the end of the treatment, while 20% improved in the control groups. You get a lot of other information about how trustworthy are the results, about heterogeneity, about sample sizes, about the quality of the studies, etc. You can also generate a report, which also includes all kinds of technical information that a patient can take to a clinician, where the methods are explained more in detail. There was one person also interested in children and adolescents, so I will briefly show that too. We also have for depression a database on children and adolescents. You see that here. And basically it works in the same way. We have not combined children and adolescents with adults, because as you will see later, the effects in children and adolescents of psychotherapies is much smaller. And here again, you can click on analyzing the data. You can, and you can say, for example, I want to know what's the evidence for psychotherapy in children below 12. And then again, you update the table and you can run a meta-analysis with this, where you get all the information again on the effects of psychological treatments for children and for children below 12. So this is what I wanted to show you. I will now continue with my presentation. So that's what I wanted to say about our meta-psy project, where we try to collect all these meta-analytic data sets. We have a standard for making meta-analytic data sets. And if you make the data of your meta-analysis in that standard, we can use it in meta-psy. But we have also developed all kinds of analysis packages in R, which make your analysis much easier. You can generate tables, you can run all these analyses right away, you can do very easily subgroup analysis, etc., etc. And that's a way in which we try to harmonize the meta-analysis field in the field of psychotherapies. But that's enough about the meta-psy project. Now I want to go to the content, and I'm going to show you what we have found over the years for the effects of psychotherapies for depression. Well, at the moment, we have more than 1,000 randomized trials on psychotherapy for depression in our database, and all kinds of different psychotherapies with direct comparisons between therapies, comparisons between psychotherapy versus control with pharmacotherapy combined, etc., etc. And so I started with this in 2007, so that's a long time ago. And when I started, I remember I was very enthusiastic in 2008 when we had more than 100 trials on psychotherapy for depression. But now we have more than 1,000. So if you wanna have an overview of all the meta-analysis we have done over 100 over the years with updates and expansions and new fields coming up. You should read this paper in the Journal of Affective Disorders, which has most of the information I present today in this presentation as well. So it's a review of all our meta-analysis we have done in this domain. And I also want to recommend a paper which we wrote last year in the American Psychologist, where we did not do a meta-analysis. Yeah, we did do a meta-analysis, but we also looked at historical developments, where the number of trials was the thing we examined. So not so much the outcomes, but just what happens in the field of psychological treatments of depression over time. And I'm not going to repeat everything, but there are a few interesting things coming out of that. And here, what you see here is what we found for the country where the studies were done. So we found that most of the research was done in the US until the mid-1990s. So almost all studies were done in the US. Since the 1990s, we see that an increasing number is being done in Europe. And at the moment, there is more research in Europe than in the United States. But what we also see is that since the year 2000, there is more and more research coming from East Asia and also from other countries, South Asia, Africa, South America, which is, I think, interesting. So the US is still an important country in terms of randomized trials, but other parts of the world, especially Europe, and more also East Asia, is taking over the role of leading the whole field. It also illustrates that research on psychotherapies is something that is considered to be important in more and more places across the world. The other thing you see is that when you look at type of therapy, that cognitive behavior therapy is by far the most examined type of therapy. And over time, it's becoming more and more dominant. So more and more research is being done in CBT, and other types of therapy are being done less and less when compared to CBT. It's still increasing, but not so much as CBT. And that means that CBT becomes more, it is already more than half of the trials are on CBT. And that dominance is only increasing over time. While other therapies like behavioral activation, where you try to motivate people to integrate more positive things in their life, it's just as effective, as we will see later. The same is true for interpersonal psychotherapy, where you focus on interpersonal problems that people have. For example, with life review therapy, maybe many of you are not familiar with life review therapy because it's done mostly in older adults, where the therapist helps the patient to look back at their life and try to stimulate a positive evaluation of their life, of their memories, and go through each of these phases. Supportive therapy is also effective. I will come back to that later. And the same is true for psychodynamic therapy and third wave therapies like acceptance and commitment and mindfulness-based CBT. I saw that one of the questions was on compassion-focused therapy. What you see here in this list are the therapies that have been examined in at least 10 randomized trials. And that means that compassion-focused therapy for depression has not yet been examined in 10 trials. But I will show you later that it is probably as effective as other therapies. Another important thing from our historical analysis is the target group. And what we see is that over time, more and more trials are being done in unselected adults. And that also an increasing number of trials is being done in people with general medical disorders like heart disease, cancer, diabetes, etc. And compared to adults, unselected adults, the number of trials, for example, in children and adolescents, is much lower than what we see in adults. And that's important because, as I will show you, therapies for children and adolescents are significantly less effective than therapies in adults. And yeah, so that's where we need more research, because that's where we need better treatments. I want to start with the content of what we found with a large network meta-analysis we did in 2021 in World Psychiatry. In this network, what you do in a network meta-analysis is you collect all the randomized trials on psychotherapies, in this case, only the therapies that were examined in at least 10 randomized trials. You see CBT, cognitive behavior therapy, BAT, behavioral activation therapy, problem-solving therapy, third wave therapies, interpersonal psychotherapy, psychodynamic therapy, non-directive supportive therapy, and life review therapy. And we collected all the randomized trials comparing one of these therapies to each other or to a control group, which is care as usual, which you see below, waitlist, or pill placebo. And so, and the size of the circles indicate how many trials were done on that therapy. And the thickness of the lines indicates how many comparisons were made between the two nodes in the network. So you can see that by far the most studies compared care as usual with CBT or waitlist with CBT. And all the other nodes were less well populated, so to say. And so we, in this network meta-analysis, we included 331 trials, 34,000 patients, all these types of therapies. And what we found, if you take care as usual as the reference, that the effect size, which we indicate as HSG, varies from 0.32 to 0.81. I will come back later to what HSG means. I will explain that later. But it indicates that all the therapies were effective, and we found no significant difference between therapies. So all the therapies had comparable effect sizes. There was one exception, that was non-directive supportive counseling. But that could be an artifact because counseling is often used as a control condition to control for common elements of all therapies. And in the trials where counseling was not explicitly used as a control condition, it was just as effective as all the other therapies. We just did a new meta-analysis last year in which we dived into that much more deeply, and we could confirm that counseling, when it's not used as a control condition, is also as effective as other therapies. So because we have so many studies, we can also look at the number of trials with low risk of bias. And there we also found the same thing. Therapies are effective, no significant differences between therapies. And we also found that the therapies had significant effects at 12 months follow-up compared to care as usual, which is important because that indicates that it has longer term outcomes. And later on, I will show you that that these outcomes are better than pharmacotherapy, actually. I will show that later on. We also did last year a very large meta-analysis specifically on cognitive behavior therapy, but that has, I won't talk too much about this because that basically supported all the other findings we find in other therapies. And so I said that the effect sizes of psychological therapies and also often drug treatments are often measured in terms of HSG Cohen's-d effect sizes, as we call them, standardized mean difference. And a HSG or a standardized mean difference indicates the difference between the control group and the treatment group after treatment in terms of standard deviations. Meaning that if you have an effect size of 0.5, that the treatment group and the control group after treatment differ 0.5 standard deviations from each other, which is definitely the best way to examine effect size, the effects of therapies, because depression is a continuous measure. And for continuous measures, it's important to have the best outcome, which is the effect size or the standardized mean difference. However, it's very difficult to explain what it means. I mean, if you have a patient in front of you who wants to know how effective this therapy is, and you have to explain, yeah, people in the treatment group compared to the control group have 0.5 standard deviation, nobody will know what you're talking about. And it's also often difficult for clinicians to understand what it means. So what we did in another meta-analysis is we looked at the absolute outcomes in terms of response, remission, reliable change, and deterioration. And in this meta-analysis, we included 228 randomized trials, including a large sample with low risk of bias. We looked at the 1 to 3 months outcomes because that's the length of most therapies. And we looked at response defined as a 50% symptom reduction from baseline to post-test. We looked at remission defined as a Hamilton D score below 7 after treatment. And we also looked at reliable improvement and reliable deterioration. Not all these trials directly reported response or remission, but we used a statistical trick to estimate the response and remission rates. And it goes too far to give the details of it, but it's well validated, that method. And this is what we found. So the response rate for therapies is overall 0.41, for CBT 0.42. And in the control groups, it's 0.17 and waitlist 0.16. Pill placebo is much higher, 0.31. Yeah, this means that at the short term, psychotherapies are effective. It's better than being in a control group. But that doesn't mean that everybody gets better. And in fact, it's a very conservative estimate of the outcomes. Because we considered all dropouts also as non-responders. So probably if you look at the real world, response rates are probably somewhat higher. And this is, by the way, very comparable to what we find for antidepressants. It's not different. I will show that later on too. So this means that we have treatments, they're good, they're not worse than in somatic care, but it still means that not everybody gets better when they get a treatment. And one of my recommendations always is that we should think more about sequential treatments. What do we do when somebody doesn't respond to a treatment? Do you give a second one? Do you give a third one? When do you start with antidepressants? Which one should you start with? Maybe the simplest or the cheapest or the one that we haven't thought about that. And I think that's a field where we should do much more research in. So this is what we found for other outcomes. Remission rates are even much lower than response rates, 26%. And there's also always this small group of people who deteriorate during therapy. So that's 1 in 20 patients who actually deteriorate during therapy. So we did this, I see that this paper is now published in the June issue of World Psychiatry. Sorry for not updating the slide. So we did the same thing for all the other, or for another group of mental disorders. So where we looked at 50% symptom reduction as a response rate for all these disorders. That's not the best outcome for all the disorders, of course, but we wanted to make one outcome across all the disorders so that you have something to compare. And what we found basically is that the response rates for anxiety disorders, PTSD and OCD are somewhere between 30 and 40%. And for borderline, that's even lower, it's 24%. And the variation is also in the control groups. Yeah, so I think it's important not only to look at relative effects, what we usually do in trials and in meta-analysis, but also at absolute outcomes, because they give a very different picture. So we also did this because there was a question about children and adolescents. We also looked at the absolute outcomes in children and adolescents for psychotherapy for depression. And what we found there, what we found is that the response rates in the therapy group was very comparable to what we find for adults. It's 39%, but the difference is in the control conditions. So the response rates in children and adolescents are 28% and 20% for care as usual and waitlist, which is much higher than in adults. And so, and that explains also what I will show later, that the effects, the relative effects, the standardized mean difference is smaller in children and adolescents, not because they respond less to therapy, but because the control condition does better in terms of outcomes. Okay, another large network meta-analysis we did. We limited this to CBT because that's the to reduce heterogeneity in this meta-analysis. We looked at how we can deliver CBT for depression. And so we looked at different treatment formats: individual therapy, group therapy, guided self-help, which is usually digital. So then you go to a website and you apply a cognitive behavioral therapy. You learn how to apply a cognitive behavioral therapy to yourself. And in the guided version, you have the support of a therapist or a coach or however you want to call it. You also have unguided self-help, which is usually also digital. So then you go to a website where you are learned how to apply a cognitive behavioral therapy to yourself without any support. And then we have telephone, therapy, CBT through the telephone. And again, we included waitlist, care as usual, and pill placebo as control conditions. And I won't go too much into the detail, but this is what we found. Here you see the standardized mean difference. So HSG or Cohen's d. And basically what this slide says is that the effects of the different treatment formats do not significantly differ from each other, as long as there's human support. And that means that you can deliver CBT individually, in groups, by telephone, digitally, as guided self-help. That really doesn't matter in terms of effects. Unguided self-help is less effective. I will show you later that unguided self-help does have effects, but the effects are clearly smaller than individual, group, and guided self-help. What you should keep in mind here is that the effects were did not differ according to treatment formats as long as there's human support. But there is the risk of dropout is higher in guided self-help. I see that I should speed up with my talk. What's important, I just said that guided and unguided self-help, has comparable effects to face-to-face. Unguided self-help has less effects, but we just found in a recent meta-analysis led by my colleague Irina Karyotaki that that's not true in low and middle income countries. So we do not find differences between guided and unguided interventions. So we did another paper on psychotherapy across different age groups, which was a conventional meta-analysis comparing psychotherapies with control groups. And then we did a meta-regression analysis across for age of the participants. And this is what we found. So it doesn't matter as when people are adults. So that's young adults, middle-aged adults, older adults. In this meta-analysis, we already also had a group of 10 studies with old people, so 75 years and older. And the effects did not significantly differ from each other in adults. But what we did find is that the effects are significantly smaller in children and also in the adolescents compared to adults. Because we have this meta-analytic research domains, for us it's also relatively easy to look at secondary outcomes. If you want to, for example, examine the effects of psychotherapy for depression on quality of life, then you will, that's a lot of work because abstracts and titles usually don't report that. But we have all the PDFs, so we just check the papers. So we have written a whole series of papers on secondary outcomes of psychotherapy for depression in adults usually. And what we see is that quality of life, that these therapies also have significant effects on quality of life, social functioning, anxiety, self-esteem, hopelessness, social support, dysfunctional thinking. I see that I have not yet updated this meta-analysis, but you see here that suicidality has only 4 trials. We recently published a paper in Lancet Psychiatry where we did an update of this, where we also found that psychotherapies for depression do have a significant effect on suicidality. There's also a small group of studies in depressed mothers of small children. And what we see in these studies is that therapy also has a positive effect on the mental health of their children, the interaction between mother and child, and on parental functioning. There is relatively little research on comorbidity. So in people with depression and anxiety disorders, or trials on people with depression and insomnia. Here you see the results of a paper we published last year on the effects of depression, of psychotherapy for depression with comorbid mental disorders. And what you see here is that when people have comorbid anxiety, that the effects are large both on anxiety and on depression. The same is true for insomnia. But when people have a comorbid substance use disorder, you see that both the effects on depression and the effects on substance use are really very small. We have done a lot of other meta-analysis. So we have found that psychotherapy is also effective in student populations, in older adults, in people with comorbid general medical disorders, and perinatal depression. We found that the effects are smaller in primary care. maybe smaller in chronic depression, but that's not certain because there is not research. When people have comorbid substance use problem, the effects are smaller when people have subthreshold depression, which makes sense because there's less room for improvement. What we do find in subthreshold depression is that in some cases it prevents the onset of major depression. And we also found that it's less effective in inpatients, but that's probably because the control conditions are also completely different than in outpatients. What we also found is that the number of sessions is not related to the outcomes. And that may come as a surprise, but it's really true. We just updated this meta-analysis, and it's published by our colleague Marketa Ciarova in the Journal of Affective Disorder this year. So there's no association between number of session, contact time, length of therapy. There is an association between frequency and outcome, and that's robust. And that means that if you give 2 therapy sessions per week, that the effect goes up considerably. We have done a new randomized trial in IPT and CBT, where we randomized people also to once a week and twice a week, and we could confirm that twice a week is better than once a week. We have done several studies in low and middle income countries, one in 2018, but we just updated that last year by a PhD student of our group, Ling Yao Tong, in psychological medicine. What we find all the time is that therapies are almost all research is done in Europe, North America, and Australia. And what we do find is that studies done in other countries have an effect size which is larger than in Western countries. That may be an artifact. It's not that much larger, and it could be an artifact because the quality is not comparable. Care as usual in low and middle income countries usually means that people get nothing, while in high income countries, care as usual can be considerable treatment. So I always try to say that psychotherapies in low and middle income countries are at least as effective as psychotherapies in high income countries, and maybe even a little better. Let's see, how am I doing in time? Can I talk for another 10 minutes? I think so, right? Yeah. Okay, so what I've talked until now is about normal meta-analysis, but what we also do is what we call individual patient data meta-analysis. And it goes to, I don't have the time to talk too much about it, but I do want to illustrate it. So we have my colleague Irina Kariotaki, she leads this whole series of individual patient data meta-analysis. And what we do is we basically ask the authors of the trials to give the data to us. And then we can do meta-analysis with the primary data. So we make one big data set, and then we can examine, for example, rare outcomes like deterioration, but also we can look at predictors of outcomes. Because individual randomized trials have statistical power to find an effect of the intervention, not to identify significant moderators. You need many more patients to do that. But if you put all these data together, you do have enough statistical power to look at predictors and moderators of outcome. And I want to just illustrate this. This is a trial, a meta-analysis of almost 40 randomized trials with almost 10,000 people in the data set. And this is a screenshot, so it's not an actual website. But if you go to this website, you can fill in the characteristic of one patient in the left side of the screen. So you have to fill in baseline severity, the age, the gender, whether the person is in a relationship status and the employment status. And then you get an estimate how guided and unguided digital interventions do for this person. So you can predict whether this person needs guided interventions, whether this person needs unguided interventions, or whether both won't do much good for this patient. And so this is really coming towards personalized therapies. And I don't have the time to go into that, but I think it's a very interesting development. Overall, by the way, it shows that when severity of depression is low, there's no significant difference between guided and unguided interventions. And both are better than carriage-usual control groups. It's only when severity goes up that guided interventions are more effective than unguided interventions. Okay, this is what I wanted to say about psychotherapies in general, but I only told you the positive things, because there are also all kinds of methodological problems with research on psychotherapies for depression, which is not unique for psychotherapy. It's all the same is true for pharmacotherapy and all the other fields in the whole biomedical field. So it's not unique for psychotherapy, but it's important to realize that there are important methodological problems in the field. So we know very well that waitlist control groups overestimate the outcomes. Most of the studies, about 80%, have some risk of bias, meaning that there are weaknesses in the design of the trial, making the outcomes uncertain. We have the problem of publication bias, and you can examine that statistically, but we actually, in one study, we looked at the trials funded by the NIH in the US, and we looked which ones were published, and we compared the two, and we went after the people who didn't publish their results, and we got the results. And so we found that publication bias actually reduces the effect size with about 25%, like in ADM studies and pharmacotherapy studies. And if you adjust for all these problems, the effect sizes drop with about 50% after adjustment for these problems, meaning that if you read a meta-analysis on psychotherapy for depression or whatever, you should really check what the outcomes are if they have adjusted for all these methodological problems. Okay. We also looked at the comparison between psychotherapies, pharmacotherapies, and their combination. We published one large network meta-analysis in World Psychiatry in 2020, where I will try to summarize the results. We had about 100 trials, 12,000 patients. Response was the primary outcome, so 50% symptom reduction. And basically what we found is that psychotherapy and pharmacotherapy have comparable effects at the short term, and combined treatment is better than either one alone. And basically, we found that that was also true for chronic and treatment-resistant depression, for severe depression, and for long-term outcomes. But we have also done another meta-analysis. which not only includes trials from our database, but also trials from other databases. This was led by my colleague Toshi Furukawa from Japan. And what we did in this meta-analysis is that we looked at trials in which people got one treatment during the acute phase and another treatment in the maintenance phase. And the total of time of these treatments was about 1 year. So people could get in the acute phase, could get psychotherapy or pharmacotherapy or combined treatments, and then they could switch in the maintenance phase, or they could keep the same treatment or switch from psychotherapy to pharmacotherapy or from pharmacotherapy to combined or the other way around. So all these different combinations were possible. And I will show you the outcome. I just showed a network plot. I like these pictures, as you can see. But these are the outcomes. And it's basically, it says that combined treatment is better than anything at the long term. But psychotherapy is also better than standard pharmacotherapy treatments at the long term. And so even if you get only once psychotherapy, that's at least as good as taking antidepressants a whole year. And if you get combined treatment, that's better than much better than pharmacotherapy alone, but it's also better than psychotherapy alone. This was, by the way, one of the meta-analysis, together with the previous one, that was used by the WHO in the recent update of the MHGAP treatment guidelines for depression, where they basically recommend not to use pharmacotherapy without psychotherapy. And I know that's not a standard in many countries, but that's still what the evidence says. But anyway, again, here we also do these individual patient data network meta-analysis. And if you're interested, you should go to this website to see where you can find the outcomes for CBESP, which is the only therapy that was developed for chronic depression. And here you can fill in all the characteristics and see whether a patient needs CBESP, medication, or the combination of the two. So some recommendations. Yeah, one thing is that the treatments we have are evidence-based, but that doesn't mean they work in each case. And if a patient doesn't respond, you don't need to doubt whether the therapy was done correctly. I mean, the low response rate is part of the treatment. And what I also often see is that people, when the therapy doesn't work, they think that they didn't do the diagnostics right. And they go back to do the diagnostics and see whether that's actually a depression. But that's not what you should do. You should consider sequential treatments when the first one doesn't work. I think especially in mild depression, you should avoid using antidepressants and give therapy. And in moderate to severe depression, combined treatment is definitely the best option. And you can try to start with psychotherapy first, and if somebody doesn't respond soon enough, you switch to combined treatment. But in the end, for combined treatment, it's definitely the best treatment. So one thing is that how can we improve treatments? Well, we don't need new treatments like compassion-focused treatments. I'm absolutely convinced that it's a good therapy, but we already have a lot of them. And in comparative trials, we always see that they don't get that new therapies, they promise to be better than the previous ones, but in good research, they're never better. they always get the same results as previous therapies. So I think it's a waste of time to develop new therapies, new formats, go to target groups. We know that therapies work in these groups. What I do think is that we need much more research on what to do when somebody doesn't respond, and what to do when in comorbid disorders, for example. So it's relatively easy to develop a new therapy, because then you can do a trial and you have enough patients to do a trial, and you can use a wait list to show that it works. But in clinical specialized care, what we see is mostly people with a depression, but also a comorbid disorder, or with a borderline, or with personality disorder, or anxiety, or whatever. But there's hardly any research. But research in these populations is also much more difficult because the samples are much smaller and people are often not willing to participate. You need, so the logistics are much more complicated, meaning that we continue to do all these research, develop new therapies which don't add anything, just show that therapies work in all these populations, while the real clinically relevant questions on comorbidity, on chronic depression, on relapse are hardly examined. I do think that personalizing treatments has a big potential, like with the IPD meta-analysis. But I also think that, for example, treatments can be improved by increasing the frequency, giving regular feedback to the therapist. Yeah, that's basically what I wanted to say. There are all kinds of other things you can do to reduce the disease burden of depression in populations, like prevention and scaling up and simplifying treatments and basic research, but that's not what we're talking about today. So I want to thank you for your attention. And I will stop sharing my screen, but if you have a question afterwards, just drop me an email. You see my email address here, and don't hesitate to send me an email if you have a question afterwards.
Thank you. Thank you very much for this stimulating and encouraging presentation, which has implications for both clinical and research activities of the audience. And I would like to remind the participants that we have participants from 28 different countries now, which is really exciting for us, for the Council of National Psychiatric Associations. And I will skip talking too much, and I will try to introduce the discussants for this webinar, who are Thomas Gargot and Selin Tanyeri Kayahan. Thomas Gargot is Associate Professor of Child and Adolescent Psychiatry in the University Hospital Tours in France. He is the coordinator of child and adolescent psychiatry training in Centre-Val de Loire region, and he is in the European Psychiatric Association. He is the chair of the section on psychotherapy and co-chair of the section of digital psychiatry. Selin Tanyeri Kayahan is from Turkey. She's a psychiatrist and psychotherapist from Turkey. She completed her psychiatry residency training in Izmir in Ege University, and she's working as an adult psychiatrist. She's practicing both individual and group psychotherapy. She's a councillor member of the European Psychiatric Association's Psychotherapy Section and in Psychiatric Association of Turkey. She is the editor of the Bulletin of the Psychiatric Association. And I will give the floor to them to discuss and direct some questions.
Thank you for your introduction, and thank you for your presentation, Professor Cuijpers. Very interesting, great talk, and very comprehensive review of the literature about psychotherapy, and especially for depression. It shows well the level of evidence that we have in this field, but instead of sometimes some like when we read meta-analysis with this new idea, here you don't have a simple answer to a simple questions, but maybe sometimes too simple. You allow us to really dive in the complexity to run our own meta-analysis, but with a very easy to use platform. It was very, very impressive. So for clinicians, but also for patients and their family, and all the limits that we have with meta-analysis about this two simple questions. Now it's like you have broken this idea. So I will let the floor for the first question to Selin.
Thank you very much, Thomas, for your extensive summary, and Professor Bashar for your kind introduction. It's such a privilege to learn from Professor Cuijpers and join the discussion. Professor Cuijpers' lecture guided us with highly impactful results regarding clinical work and many practical implications for mental health services. I'd like to start by emphasizing that most of the disease burden for depression is found in low and middle income countries where mental health care infrastructure is limited. And what this practically means is that probably most people who would benefit from effective psychological treatments for depression cannot access them. And the similar is also, it applies to any other low resource setting in high income countries too. Here, Professor Cuijpers mentioned that simplified versions of psychological treatment, that they might be a vital opportunity to provide brief, affordable, more easily available options for broader populations. And again, various formats of delivering psychotherapy, for example, internet-based interventions, they show similar effectiveness. And it also seems important to involve human support. And we know that a significant barrier for the access to psychotherapy is the lack of skilled mental health professionals. So I would like to ask, how can we optimize guidance of self-help interventions? And what are your insights on possible advantages of task-sharing psychotherapies in especially low-resource settings? Thank you.
Yeah, thank you for raising this. So what I try to do is give an overview of all the research we've done, and so I didn't have the chance to also dive into this. But actually, this is one of the things we have been examining quite extensively, and we did one individual patient data meta-analysis on task sharing interventions for depression, which was published, I think, last year or 2 years ago in JAMA Psychiatry. And apart from the meta-analytic work I do, I also am involved in a lot of research in low and middle income countries on psychological interventions. And I think the potential, of course, lay health counselors are an important solution. We know that now for quite a long time. We can train nurses in primary care centers to deliver simplified psychological treatments. That's the evidence is quite convincing, and that's also already being implemented on quite a large scale. Not, of course, for the 80% of the people with mental disorders in low and middle income countries, but it is scaled up quite extensively. I also think that it is possible to extend treatments by digital interventions. We did one trial in Lebanon, which was published last year in PLOS Medicine. It were actually 2 randomized trials in which we adapted PM+, which is a brief intervention developed by the WHO. We adapted that to the smartphone. That means that people can just have a smartphone app where they approach a psychological treatment, and they were supported by trained lay counselors on a national level. So they were, because it's through the smartphone, you can do that on a national level. And the effect, and we did one trial separately in Syrian refugees. There are more than 1 million Syrian refugees in Lebanon. And one other trial for the other people living in Lebanon. And we actually found pretty good results, which are very comparable to what we find for normal treatments in our meta-analysis. And so I think digital interventions really have a potential to scale up interventions. And I also give a lot of lectures about scaling up interventions in lower middle income countries. What I usually say is that I think that when countries have very little resources, they should start with building a system of unguided interventions. Because we found, as I showed this meta-analysis, unguided interventions are probably as effective as face-to-face, as guided self-help, and probably also as face-to-face interventions in lower middle income countries. And of course, it takes an investment. Because you have to make a system, it has to be safe, it has to be updated every couple of years, etc., etc. So it's not nothing. But compared to building a system of mental health care, it's relatively cheap. So if you start with, when a community can start with unguided interventions, if there are more resources, they can start a digital platform with guided, where you have trained health counselors working on a national level. Because it's digital, they don't need to be located in a specific place. And if you then have more resources, you can start integrating lay health counselors in primary care centers across the world. And if you have then more money, you can start developing a whole mental health care infrastructure. I should note that the focus is then on digital interventions, of course, but our research clearly shows that you can do the same thing with books and telephone support. So it's you can give also people, just give them a self-help book. And if you have can give guided support, you can just do that as well, just by telephone, old-fashioned, old school. That works just as well. So it doesn't have to be a fancy website or whatever. Yeah. Of course, that still limits the access, because not everybody can read and not everybody has access to these things. But it's a start. And I mean, you have to start somewhere.
Mm-hmm. Thank you for your answer. We had a question what was very related about the dissemination of evidence-based therapy on the internet, cognitive behavior therapy, all this self-help materials that can be done. Maybe you said that investment was important, but maybe there are some sociological factors that slow down the dissemination. I don't know, about reluctance to use technologies or to use books because they could replace therapists and it could be very bad for us, some psychologists, or I don't know, about only habits that we have. What do you think about that?
Definitely. I mean, it's not easy, otherwise it would have been done already. So there are, and it's, I mean, it really depends on the community you work with. And many people don't even have a word for depression. They have other words, so they don't have a word. So in other communities, the stigma is extremely high. And all these factors, they limit the dissemination. And it will, I mean, we're talking about 800 million people with mental health problems. And so we cannot expect that we have that solved in a couple of years. So we have to begin somewhere. And there are lots of, and money is one thing, but expertise is another, the political will is another. And then you have the patient level, you have the service level. All these barriers there are lots of barriers. So it's not easy, certainly not. But we're exploring in a lot of places, how can we do that? What works, what doesn't work? And I mean, the advantage of digital interventions is that there is no border. And I mean, there are these websites in Australia and in the US, and they have Spanish versions of their websites. And they get, Australian websites, they get a lot of visitors from the US, from the UK, from India. You get, if you have a Spanish website, you have whole South America. So you won't be able to reach everybody, but when you think about global mental health and the 800 million people we're talking about, you should remember there are more people with depression in China than the whole population of Spain. There are more adolescents with a depression in India than the whole population of Holland. So when you think about the scale of what we're talking about, then if you have an intervention that only has tiny effects, but you can implement that into China, and you can reach a part of that 50 million people with, then the total impact is enormous. And so you can start building an infrastructure for mental health care in China, where you have people treating individually, etc. But if you have an intervention with a tiny effect, but which reaches 5 million people, the impact on mental health is much larger than building up a... So when you think about global mental health, you have to think in a different way. You have to think about scalability. You have to think about brief interventions which can be disseminated. And if you have a digital intervention in Spanish or in Chinese, which reaches lots of people, then you have not reached everybody. You have not solved the problem, but you do more than building up a clinic somewhere in India. And that's so it's when you think about global mental health, it requires a different way of thinking. You have to think about the numbers. You have to think about scalability. You have to think about that you will not be able to solve the problem for one country at once, but you have to do it in slices, so to say.
Thank you very much. I would like to ask another question from a practical point of view. As you mentioned, combined treatment is recommended for severe and moderate depression. And for mild depression, psychotherapy seems like a better option, maybe, since it maximizes the chance of not only short-term effects, but longer-term effects.
Yes.
And I'd like to ask, among the evidence-based psychotherapy modalities, are there any differences on effectiveness, particularly regarding the longer-term effects?
That refers to our network meta-analysis in 2021 in World Psychiatry. So what we found is that all therapies have comparable effects at the short term. And we also found for the trials which reported at the long-term outcomes that there are also long-term outcomes. We did find that problem-solving therapy was a little more effective than other therapies, but the number of trials is so small that you really have to be very careful with it. And I think currently, with the current state of knowledge, I think it doesn't, you can extend the short-term effects to the long-term effects. So meaning that you can use any therapy of the ones that have been examined in more than 10 trials, and they probably also have long-term effects after 1 year, which we call long-term, but which is not actually long-term, of course. It's still intermediate. Yeah.
Maybe we need to be more precise in the questions that we want to ask in this literature, for instance, long-term effects. And I had a question also about the quality of the studies. Do you think we should improve the quality of the study, or it's strong enough? It's not really the problem. Maybe the problem, it's more urgent to think about implementation and scaling up. What do you think about that?
I think we do need to improve the quality of randomized trials, definitely. I mean, the 80% have some risk of bias. I mean, that's terrible.
And it's worse than in a pharmacotherapy trials?
No, it's not worse in pharmacotherapy. I mean, this is a problem across the whole biomedical field. Trials are just not good enough. So I do think that we have to improve the trials, not only the quality, but also the reporting. We see that every day when we do meta-analysis. But that doesn't mean we should do the same trials. I mean, for psychotherapy for depression, we have so many trials also with low risk of bias that we know that they work. We don't have to repeat at the new high quality. We have to do different trials on sequential treatments on people with depression and a comorbid personality. We found one trial in people with depression and comorbid personality disorders. Well, when you look at specialized mental health care, that's more the rule than the exception.
Exactly. Yeah.
So the basic. So we should definitely improve the quality of the trials, but also have a refocus of the content of the trials.
Maybe we should pass on to the questions that have arrived from the audience, and maybe I can start with asking the role of gender in the effectiveness of psychotherapies. Are there any clues that you can provide us?
Yeah, we never find an association between outcome and gender, never. We do not find that in meta-analysis. So we have trials, there are lots of trials only in women. We have a few trials only in men. You have all these trials with proportions of women. We never find an association, but we also have quite a few IPD meta-analysis where we have the primary data. And I've never seen one indication that gender is a predictor or a moderator of outcome, never.
And also we have some other questions related to the protocol of the CBT, but I don't know if the meta-analysis is the way to provide us information about such a detail. Are there any differences between protocols of cognitive behavioral therapies?
Yeah, so we define CBT quite broadly, meaning that if cognitive restructuring is part of it, we call it CBT. But we have also looked at specific types of CBT. And I think it was a study in 2019 in psychotherapy research where we looked at subtypes of therapies. And we included subtypes of CBT. And we differentiated between trials which used Beck's manual, trials with the format of the Coping with Depression course, originally developed by Pete Lewinson and Ricardo Munoz. And I think we also had a sample of studies using the self-help book from David Burns about depression. And so we could differentiate these subgroups of CBT. And they didn't differentiate. There was not a significant difference between the subtypes of CBT that we found. Yeah, which basically supports that all the well-designed, well-manualized therapies, that they all work.
There is an important efficacy of behavioral activation, which is very simple, that can be given by nurses. You said the word, maybe you can explain more what is it and how to maybe improve the training on behavior, on the accessibility.
Yeah. I mean, behavioral activation is relatively simple. it's a behavioral approach. So you talk with patients about things they like, which give them a good feeling. And then they say, yeah, but I'm depressed, I don't feel. But then you talk about what they used to like. And that can be anything. That can be, you know, talking with friends, going to the movies, drinking a cup of coffee in the garden when the sun shines. And it's the patient who decides what positive things she or he has. And then when you have that list of the 10 or 15 or 20 most important positive experiences, the patient tries to build that in the weekly schedule. And so you plan your week in advance, and you say, on Monday I'm going to do this pleasant activity and that pleasant activity, and on Tuesday that and that. And then it sounds easier than it is. It is in practice it's much more complicated. Patients come up with a young mother who takes care of a kid all day, and then she should do something nice. No, she is working all day to get the kids into bed, and then she's exhausted. So you have all these practical problems. It sounds easier than it is to do it. The basics is that it's based on social learning theory, built in positive interactions with your environment in your daily life. And it works, it's relatively simple. It can be done by nurses. There is this big trial in the UK where they trained nurses to deliver it. So yeah, I think it's a very good treatment. But it's the behavioral activation therapy. There are also different kinds of it. So the simple version delivered by nurses in the UK is something completely different from the contextual behavioral activation developed in the US, which is much more extensive and which has much more elements of third wave therapies. So
it's less costly than more broad CBT. There was studies comparing both, and it's much more simple. And it shows that it's important to be pragmatic in therapy and not to forget to planify new behaviors.
Absolutely, absolutely. And I think problem-solving therapy is very comparable. That can also be very well done in primary care. And it's also this very practical way of solving problems, which is very effective.
We only have a few minutes left, but I want to ask, combining two questions that arrived from earlier participants. One of them is, what can you say about the effectiveness of supportive psychotherapies? And one of them is, what do you think about the exclusion of psychodynamic psychotherapy from the psychological interventions manual by WHO?
I saw that letter. Yeah. I think, I mean, you have to realize that the WHO is aimed at the 80% of the people in low and middle income countries who have hardly access to evidence-based therapies. And psychodynamic therapies are wonderful. I mean, I don't have a preference for any type of therapy, but I don't think that I could find one trial examining psychodynamic therapy in low and middle income countries. And so I was a bit surprised by this, let's call it this question, because I mean, the WHO has this goal of helping these 80%, these 800 million people. And when there is a type of therapy which is only examined in high income countries, which probably is not very adaptable to low resource settings, but maybe, yeah, you don't know, maybe it is. And there's no research in low resource settings, then I think you somehow missed the idea of global mental health.
All the all the psychotherapies are equal, but some of them are more scalable, less costly, and easier to implement, and maybe.
Yes. Yeah, absolutely. And I think there's nothing wrong. I've been involved in several trials on psychodynamic therapy myself, and many meta-analysis. And I think it's a wonderful therapy. But I don't think it's something, if you want to use that in low and middle income countries, you really have to do research and rethink how that therapy can be done in low and middle income countries. And that's not done yet. There's hardly any research.
And maybe one more question. But are there any differences in the long-term efficacy of the short-term and long-term therapies? That, I mean, you discussed the number of sessions in CBT, but I mean, with regard to the length of therapy, are there any differences in the long-term effectiveness?
Well, we adjusted for the number of sessions. What I often hear is that most research is on short-term therapies, and that's suggesting that long-term therapies are more effective. But there is no research. There is hardly any research on long-term therapy. That's the problem. And maybe they are more effective at the longer term. Very well possible. I'm open to that. It makes sense to me that they're more effective. But there's just no evidence. So we don't know whether long-term therapies have better effects at the longer term. We just don't know.
One final question asks if whether it could be possible to test these meta-analytic conclusions in real-life depression. Do you think it's possible to make a research like that, like the study trial in pharmacotherapy? I don't know if you can do that in psychotherapy.
I think most of these trials are done in real life. So yes. They are done in clinical centers and primary care, sometimes in university centers. But usually we do not find a difference between the setting where the trials were done. So I think they are pretty real life already.
They are pragmatic.
Know how to do that more than they already are. Yeah.
Okay, I think we are actually out of time, but we have some still questions, and I think our discussants maybe want to ask some questions more, but I think we are already finished the 90 minutes that we have been allocated for this great presentation and discussion. I would like to thank you all for participating in that webinar, and thank you for your presentation, and thank you for your stimulating discussion, Selin and Thomas. Thank you all for participating. This is recorded and this could be achieved online by the members of the psychiatric associations, which are also members of the European Psychiatric Association. Thank you all for being here in this afternoon. Thank you all.
Thank you for your organization. Thank you very much.
Thank you very much for the organization.
Thanks. Thank you.
Bye.
Bye-bye.
Bye-bye.